First of all, I'd like to thank Professor Mahmoud Salah and Professor Ahmed for the great gathering. It's always a great pleasure to be back with you in vascular art. I was simply asked to prepare a presentation about venous nightmares. And I can tell you that although veins are so calm and forgiving, veins are forgiving, but actually you can get lots of storms if you're not thinking with the right side of the brain. Because one thing for sure, one thing for sure is that our brains are not only right and left sides. They are classified and categorized into the blue side and the red side as well. So remember always when you're treating veins to think with the blue side of your brain, because that makes a lot of difference. And we'll be discussing simply two cases. Those two cases, when you look at those pictures, your first impression would be that those patients must have IVC occlusion. But let's dig into the facts underlying. The first patient actually is a lady who presented to us in 2014. She had a history, she was 28 years old, had a history of abdominal pain, ascites, and hepatomegaly 2 years before she presented to us, which was diagnosed as Budd-Chiari syndrome, and an interventional radiologist did TIPS for her, after which she was anticoagulated. 6 months later, she noticed that she started to develop anterior abdominal wall varicosities. And a CTV done in acute, actually her husband was a radiologist, was diagnosed as total IVC occlusion with extensive anterior abdominal wall collaterals, and you can see how huge collaterals she had on her belly. After she spent 2 years trying to get pregnant, she couldn't, and having a miserable life with those veins getting bigger and bigger. She had also recurrent superficial thrombophlebitis of those veins, and she was already anticoagulated when she came to us. So that was her picture. Unfortunately, the video is not working, but actually you could see the contrast flowing till the iliac veins, and the IVC actually had no contrast at all inside. When she came to us, first thing, when we reviewed her CT, we thought that that IVC, which was diagnosed as an occluded IVC, was not occluded. Why we thought this way? Because we never seen a dilated IVC that big, as you can see in the picture. We can call it a chronically occluded IVC. That never happens. Also, she had a dilated azygos vein, which you could see clearly in the cuts, that the azygos vein was dilated and the IVC was dilated in diameter, although no contrast whatsoever is actually inside the veins. So we had that assumption that the IVC was patent, but we have a reversal of flow in the IVC in the downward direction rather than going up, growing down to the collaterals and then coming up through the anterior abdominal wall vessels. But that was actually at that time, that was just fantasy. So we thought if we do a CT venogram, but this time putting some weights on her belly to try to impede the flow in the superficial veins so that we force the contrast to go into the deep veins, that would give us a clear picture, and that assumption would be valid if we found the contrast flowing into IVC. But unfortunately, we failed. We tried this, we put some saline bottles and wrapped it around her belly in order to force the contrast, but it didn't work. We still got the same pictures with that dilated IVC without even a pinch of contrast inside. So our next plan was to get this lady into the cath lab and do a diagnostic venography. So that's what we've seen. When we go, and you can see the contrast doesn't flow into the IVC, but putting a catheter in, we could find that exactly what we assumed. The contrast flows downwards in the IVC for some reason that we could not understand at that time. But the flow of contrast goes down the IVC into the iliacs and then back in the superficial collaterals. And going deeper and deeper with the catheter, we could see that she had an occluded suprahepatic portion of the IVC. As we all know, the bad Chiari syndrome is 3 types. The type 1 actually is truncal type. It's the occluded suprahepatic portion of the IVC without any involvement of the hepatic veins, and that's exactly what this lady had. So we could see the suprahepatic IVC occlusion, although the tips connected the hepatic, just connected the portal circulation to the hepatic veins, but actually the problem was not in the hepatic veins from the start. So going with a Atlas balloon, 24 millimeters, we could dilate, and then we could see the contrast now after dilatation flows down upwards. We put a stent, wall stent, 24 millimeter by 60, and then you can see the final venogram with the contrast flowing in the right direction. So that was her images before, and that's after just stenting her suprahepatic IVC. You can see clearly that most of the collaterals disappeared. So a CTV, again, the video is not working, sorry for that. A CTV done 6-month follow-up, we could see clearly that all collaterals disappeared except of the left side. And in the CT venogram, we could see clearly that she had severe compression of the left iliac vein. So we took her again and put a stent in the left iliac, and a CTV afterwards showed that they shrinked in size again. So that lady, now 8 years follow-up, she was kept on aspirin during this period after the 1 year of anticoagulation. She became pregnant after 2 years, and we gave her low molecular weight heparin during pregnancy. She delivered safely, and after 5 years of the intervention, she had just moderate in-stent restenosis. She had recurrence of the same symptoms again. So we did a CT venogram and could find in-stent restenosis, which was dilated again just by ballooning, and had excellent flow afterwards, and she's happy. So that was one case. The other case, as you can see, shows the same abdominal wall varicose veins, but actually this patient was a 45-year-old male, actually presented with dyspnea, face and neck swelling, distended neck and abdominal veins. So he was already diagnosed as having superior vena cava syndrome. But what about the abdominal veins? We couldn't understand. Doing a CT for the patient showed a suspicious mass compressing and encasing the superior vena cava, as well as the proximal brachiocephalic veins, which was actually proposed by the radiologist to be a calcific lymph node, maybe occluding the superior vena cava. So one important thing is that these collaterals came because the superior vena cava, the lesion actually was occluding the azygos vein collateral, because it was, if it was not occluded, we could find the intra-abdominal veins dilated, but actually occluding the superior vena cava as well as the azygos vein, as in this type, forced the blood into the internal thoracic veins or internal mammary veins as a collateral pathway, and that's why we could see, but this time the direction of the flow is not from down upwards, it's from up down, to try to drain the superior vena cava into the inferior vena cava but through the abdominal wall veins. So those are usually the pathways through when the azygos is involved, the internal thoracic vein and the lateral thoracic vein, and those exactly are the main veins on that gentleman's belly. So the plan was for the cardiothorax to go into the mediastinum and take a biopsy, but unfortunately they informed us that they had to break 2 scalpels taking a biopsy from that lesion, so it was really tough. They succeeded in the end to take some part, but after breaking 2 scalpels, that was very relaxing. And it was diagnosed as fibrosing mediastinitis. Actually, that was my first time to know about something like that, but it's actually something like retroperitoneal fibrosis. It's idiopathic, it's rare, but it's actually, it can occlude the superior vena cava, it can occlude the pulmonary vessels, and it can occlude the esophagus and the trachea in some cases. So we thought we could recanalize that lesion. We went through the internal jugular as well, the femoral vein, double axis, forcing trial wire passage with different wires, with different catheters from below. We could not go and pass and cross the lesion. We used an Asahi Astato wire coming again from below, but at some point we tried to do sharp recanalization. It didn't work, and at some point you could see the wire, and that was dangerous because we could actually do mediastinal perforation if we proceed further. So we stopped trying from below. We went from above again, trying to recanalize again. doing sharp recanalization, but at this point we had to stop so that not to injure the pericardium. So again, finally, we failed. We failed to pass that very extremely tough lesion. So the plan, we went to the rheumatology. We told them we would think that this as fibrosing mediastinitis, it can respond, as the literature says, to pulsed steroid therapy and biologics. Nonsense. 3 months after CT venography, the same, and the patient was still symptomatic. So we had to go for an MDT meeting with the cardiothoracic surgery, and we planned for a bypass because we failed endovascular, and I didn't have any optimism that if we go again, we would do something better. So we planned that he would do a pericardial tube graft self-made from a pericardial patch to go with recanalizing the left brachiocephalic, and we do a PTFE graft on the right side. And that's exactly what we did. Sternotomy with the right infraclavicular incision. Through the sternotomy, you can see this is a self-made pericardial spiral tube graft, and you can see how it fills well from the left brachiocephalic. That was the first part. And the second part was our part is actually doing the bypass graft through PTFE ringed graft to the subclavian vein. And this was the final result with that bypass. So afterwards, the patient's veins, you can see clearly how they improved. The symptoms, the patient is really happy. His symptoms are totally relieved. The edema, the facial and neck edema is totally relieved. So that was good. So abdominal wall varicose veins is definitely not a cosmetic concern, and it denotes a caval occlusion inside, but actually it can be the IVC or the superior vena cava, and high-quality imaging and interpretation is mandatory before you decide doing anything for patients with abdominal wall varicose veins. Caval stenting is safe and durable. Occlusions are sometimes very challenging to cross, as the patient I showed you, and still bypass can be useful in case of failed endovascular procedures. And thank you for listening.